get ourselves ready to go. I just want to start with welcoming everyone to Forge Health's first Pride panel. As many of you are aware, Forge Health is an outpatient and IOP behavioral health program operating in person and virtually in 5 states: New Jersey, Pennsylvania, New York, Massachusetts, and New Hampshire. We serve adults in the general population, the first responder, veteran, and active duty military population. And we also serve and work with members of the LGBTQIA+ community with our Pride at Forge programming. Our panel today, Forging a Path, Overcoming Barriers to LGBTQ+ Health Equity, will be focusing on improving healthcare access and outcomes for LGBTQ+ individuals and exploring strategies for promoting health equity more broadly. This is an area of importance at Forge Health. This is an area of importance at Forge Health. We're going to be addressing topics such as discrimination, stigma, and access to care. We believe it's important to build connections between healthcare providers, community organizations, and the individuals that we are serving in those communities. My name is Michael McCann. I'm the Executive Director of New Jersey and Eastern Pennsylvania. I'm joined today by our Senior VP of Business Transformation, Dr. Cleo Lightfoot Booker, to help me in moderating this panel. As a housekeeping item, you feel free to submit any questions you'd like for a panelist to answer. We're going to leave some time at the end of the panel, and Dr. Booker will be helping me to organize some of those questions and bring them to the panel. I'd like to provide some introductions. First, I'm going to start with Robin Gottlieb. He is a practicing family medicine physician and the medical director of Northwell Health's LGBT Healthcare Center of Excellence in Sleepy Hollow, New York. The center provides full LGBTQ+ services, including routine care, preventative care, PrEP, PEP, and transgender hormones in a welcoming and safe environment. Dr. Gottlieb also serves as the medical director of ambulatory primary care and medical specialty services, Northern Subregion for Northwell Health Physician Partners. Melissa Dominguez, LCSW, is a queer Latinx licensed clinical social worker and founder of As You Are Therapy. Melissa's specialty and scope of work centers on addressing the unique mental health needs of the BIPOC and LGBTQIA+ communities by providing therapy in a private practice setting. Her experience in social work and mental health field includes advocating for vulnerable and marginalized populations, such as families in the child welfare system, adults diagnosed with severe mental illness and co-occurring disorders, and survivors of domestic violence and human trafficking who lack access to medical and mental health care. We are also joined by Patrina Sexton-Topper, PhD and RN. Patrina is a PhD prepared nurse, researcher, massage therapist, and body worker and entrepreneur. Patrina earned a BA in sociology from the University of Dayton and has a degree in clinical massage therapy from the Soma Institute of Chicago. She pursued women's studies and human sciences at George Washington University in Washington, D.C., and ran her own clinical massage therapy and bodywork practices for over a decade. Patrina completed a Master's of Science degree in bioethics from Columbia University and was a Hillman Scholar in Nursing Innovation at the University of Pennsylvania, where she earned BSN and PhD degrees and completed a 2-year fellowship that focused on sexual and gender minority health and health disparities. She is currently building a new organization that pairs nursing with hands-on interventions to support those in periods of health transition, and she is the part owner of the Teal Center for Therapeutic Bodywork in Arlington, Virginia. And finally, we have Jake Prigoff. Jake is a partner at Gangels, which is one of the largest, most active private investors dedicated to supporting diversity and inclusion within the venture capital ecosystem. After battling stage 4 lymphoma, Jake was driven to become active in healthcare as a speaker, advocate, and physician. He attended medical school at Mount Sinai School of Medicine in New York City and trained in general surgery at Columbia University Medical Center. Jake left clinical medicine to pursue broader systemic impact on the healthcare system as an investor. I want to thank you all for joining us this afternoon. So I want to get us kind of kicked right off. and I'm going to kind of move through each of our panelists with kind of a question each, and hopefully spark some great conversation. So I'm going to start with Patrina. In your experience, what are some of the unique healthcare needs of LGBTQ plus individuals that have often been overlooked or misunderstood?
Yeah, I would love to hear the other panelists chime in on this one too, given our the wide breadth of experience in clinical settings. One of the ones, given my research background, is the desire for folks to become pregnant or to parent. Folks across the LGBTQ plus spectrum, regardless of their background. So in previous generations, it would probably be understood that folks do not want that necessarily. There were normative ideas around whether or not LGBTQ people would want to grow families of their own. And today it's become more visible in the public domain, but healthcare settings are not equipped necessarily to work with people across the LGBTQ spectrum who would like to become parents. And insurers certainly don't necessarily cover us, given the unique needs that we have and the tailored interventions that we need to fulfill that innate desire that many people have. Across the board, having tailored interventions where our bodies and our beings are legible to providers is a big issue still. A trans person may come into their primary care provider, and Robbins, you could probably speak to this really specifically, and they may be unlegible to that provider in terms of what their specific needs are at any given moment over the course of just a general care, and or whether they're in transition medically or surgically. There are a wide array. PrEP and PEP, of course, are issues that, or their interventions that remain challenging for people depending on where they're located regionally in the United States. So there are a wide array of things, and I would love for other people to chime in on needs. I just sort of identified a few.
Robin, do you want to jump in there?
That was a great start, Patrina. Thank you. I agree with that. You know, one of the big things is gender affirmation. I don't have cisgender people come into my office asking for any sort of affirmation of their gender. Our medical establishment is set up to help those people, and they get everything they need at any doctor, any provider they want to see. But my transgender, gender non-binary patients, they need that, and that's missing, and that's unique, and that's special. And not a lot of doctors, unfortunately, do it, although the profession is getting better, but it is a huge thing that makes our population so unique. And so affirming these people's genders, helping them with what they need with their gender journeys is such an important and beautiful part of the care that we can provide. And it spills over from their physical health to their mental health. It's really all encompassing. So I'm really glad you touched on that. And you also touched on HIV, which anybody can get HIV, right? But we're still seeing higher numbers in our LGBT population. And there's so many tools we have to stop the spread. And so there's so much we can do on these fronts, and they are unique, and we need more help and more access to patients, which we'll talk about later.
I'm happy to chime in as well. I think those are fantastic disparities to point out within the LGBTQ health population. I think there are ones that often go unrecognized as well. There are certain subsets of the population where obesity is more common. There's certain subsets of the population where cervical cancer, anorectal cancers, head and neck cancers are more common. And those often go overlooked or unnoticed in terms of addressing LGBTQ health issues. One of the ones, and both of you certainly alluded to this, is the social determinant of health that has, I think, the largest impact on our community, which is the lack of culturally and clinically competent providers. And we're starting to see a lot of really great progress in terms of medical education, but there's still certainly a gap in terms of the number of patients that need specialized care and the number of providers who are culturally and clinically competent in providing that care.
I want to throw in one more thing, which is screening for cancer. That is, not unique per se, but we just don't access it. I think for a lot of our community, they're anxious to go to a doctor, and just to see a primary care doctor can be overwhelming. But then to think they have to go to a specialist, a gastroenterologist, who's going to look at their butt, and they might be worried because they're at higher risk for cancer because of HPV, but they don't want to bring it up in their partners and what they use for sex. And all that's really scary, especially when you're talking to someone who doesn't get the LGBT community. So we're way behind, and I think screening, and our community is unnecessarily suffering the consequences of preventable cancers.
Thank you. Melissa, is there anything you had wanted to add?
No, I agree. I think part of one of the questions that I was going to be answering was kind of how it's the responsibility of our cishet healthcare providers and their staff to create that environment. A lot of times it's put on the LGBTQIA population themselves, but it shouldn't be the sole responsibility of queer individuals, and the representation needs to be present from the moment that someone walks through the door to seek access to healthcare. So that looks like signage, gender neutral bathrooms, inclusive language on intake, medical paperwork, electronic health record system. And in my personal opinion, one of the most harmful things a provider can do or staff member can do is assume. I think a lot of times people are afraid to ask questions, to seek clarification, to listen to their patients, especially their Black and Brown patients whose symptoms are overlooked and minimized. And we know the catastrophic effects that that takes on in our medical system, that Black and Brown people are being overlooked and ignored. And so, yeah, I agree with that. I think we're very behind still. And I have a number of clients that come to me who are transitioning, who have accessed the healthcare system for gender affirming healthcare and who have been traumatized by the system and the providers.
I would just want to add, like, as a nurse, we generally think very holistically about not only the patient, but their families, the social determinants, as Jake pointed to, of health and what the context. And oftentimes, if somebody's accompanied by a significant other into a clinical care setting, and that significant other or their child is misinterpreted in some way, that's that has multiple forms of traumatization that occurs as a result of relationships, which again makes it aversive. Like, it's an aversion then that folks don't want to go into a clinical care setting because of the forms of trauma that they can encounter that are also relational in nature. And so it's important to think about that if you, for example, are coming in with your child to an emergency department and ask for insurance information about your husband or your wife, and neither of those things apply to you, and the person who is taking that information can't quite comprehend that you're not in a heterosexual cisgender formatted relationship dynamic or family, it can really complicate an already very traumatizing situation, right? And that can happen at many layers in many kinds of encounters. And so just to add that to the mixture here.
You're muted.
Michael, you're muted.
Thank you. I want to jump ahead a little bit, but because we're kind of already talking about this. So what are some of the all of your thoughts of what healthcare providers can be doing to create that more inclusive environment that is culturally competent when it comes not only to working and to all of your points, not just LGBTQIA plus folks, but also people of color who might feel already traumatized from medical systems? And I'm going to have Melissa start on that one, since you kind of started talking about that already.
Yeah, I think, like I was saying earlier, I think it's important that there's representation in healthcare and that we have that in our providers and with the staff members, people that look like us, people that are not, like I said earlier, not going to assume things about us, either Black and brown people and or the LGBTQIA community.
From a more systems perspective, I think that there are opportunities to engage with experts on this. There is a company that I chat with and am an investor in called Violet. And what they do is they help healthcare companies, whether it's a private company or a health system, improve upon their DEI and health equity initiatives. And they come in, evaluate the current practices, and then help those systems improve. And so I think, we could give kind of, advice here, but nothing beats engaging with experts on this and changing the system that these patients are entering.
I like you talking about that because there's so many different ways to approach it. In my office and in doctors' offices, it starts at the front door. If you get a pride flag right there, we have a sticker in the front door, sticker at the window. We'll use a progress pride flag, the relatively newer one with the triangle in the corner that really represents some of our communities, the BIPOC communities that have been marginalized forever, even within our marginalized group, which is a shame. So having that visible from the very get-go, having flags around, having badges that have pronouns on them, having forms that are right, Jake talking about IT, having systems that can capture the person's actual name and gender, all of that makes people feel less marginalized, more accepted, and leads to better outcomes as far as their medical care as well.
Yeah, and just to further that point, the representation piece is critical, and people slowing down to encounter another human being. I mean, the health disparities and equity work are about recognizing each person's dignity. And if we encounter one another at an individual level, there are certainly systems level modifications that can be made. But if we encounter one another as human beings and try to understand where another person is coming from, that is critical. That initial encounter is great, but the follow-up that can integrate IT systems to flag, right, to include things that remind providers across a setting that this person's gender identity is X, Y, and Z. Their sexual orientation is X, Y, and Z. And so that people don't have to go in each time and remind staff members and providers who we are and what we're doing there for a visit. Flagging things in IT systems and having those, again, using the word legible, across staff members is really a critical, easily modifiable thing that we can do. And having insurance companies and ways that people are covered also be more expansive.
So, and Robbins, you had talked a little bit about, and Patrina as well, talking about creating systems to have an approach within healthcare systems to ensure that we're trying to reduce these disparities, improve outcomes. What are some innovative approaches that you can think of that you either you're currently engaging on, or you've seen engaged in, or that you've had clients bring to you that have really ensured that promotion of equity, of being seen, of being affirmed in their medical settings?
Well, first of all, for years, we've been shamed as gay people, LGBT people. Society shamed us, said we were bad, we weren't doing the right thing. It's a terrible thing that happened. We really need to shame, not ourselves, but shame these big organizations that aren't making change. if they're not paying for technology that will update their systems to capture this kind of data, then shame on them. And we need to hold them accountable. It takes time. It takes a lot of money. I recognize that. But if that's not on one of their checklists of what their electronic health record must contain, then it needs to be there. It needs to be at the top. So we need to work with these health systems and hold them accountable and be very vocal about it to help them change. That is an IT challenge, and that's what it's going to come from. It's going to take money and time and buy-in from the highest powers.
I think Jake also is speaking to the Violet as an intervention that's evaluatable. To assess whether or not changes occur with the modules that Violet introduces, but it's a training mechanism, and training that also meets people where they are is going to be critical. Yeah. So and Jake and Melissa, I think you have more to say about that probably.
Yeah, thanks for bringing that up, Katrina. I think it's really important to acknowledge, kind of what Robbins was saying around shaming these organizations, but it is accompanied with something, or needs to be accompanied with achievable intervention. And we can't let perfect be the enemy of progress. And if we're going to shame these organizations, then we, as leaders in the space, need to provide them access to resources that actually allow them to improve. And so that's something like Violet, where the company is focused on engaging with these health systems and helping them improve, and meeting them where they are and moving them forward in a way that aligns with everybody's hope for what health equity will look like. And so I think it's important to acknowledge that the resources exist out there, and it's up to health systems to find them. It's up to us as leaders in the space to provide them. And it will take time, it will take money, it will take energy, but it is achievable.
The other thing I think we have to recognize is we're consumers and we have power. We need to vote with our feet. You may or may not know, but there's already organizations doing this. The HRC, Human Rights Campaign, they have that Health Equity Index, where they actually rate all the health systems across the country who will participate and give them a score on their health equity. We're talking about health equity here. Do they have systems in place? Do they care about you as an LGBT consumer? Do they have protections for you that you won't be harassed, that you'll get the care you deserve? You should look up your local healthcare institutions and see how they rate on that health equity index. If they're not getting a perfect score and there's a system next to you that is, go to that other system. Save yourself the trip and the pain of going to some place that doesn't care about you. Support the hospitals and health systems that are trying to make a difference. As Jake points out, they're still not perfect, but at least they're trying. And those are the systems we want to support and want to go to as consumers. So everybody listening to this panel, look that up and only support those support systems that support us.
So can I ask, as a follow-up to that, how do we encourage and educate members of the LGBTQ community to be looking for that, instead of, I think, being okay with essentially the status quo of being involved in healthcare systems that are not affirming and that are not validating?
Well, I think that's the first step. HRC tries to educate people about this, but most people don't know. And I think it's panels like this that gets the word out, hopefully Pride celebrations, and that can make an impact as well. There's a lot of other resources that you can look at, big medical groups that are trying to find competent providers, doctors, PAs, NPs, and they have lists. I have signed up for multiple lists through organizations that try to curate providers that are competent. So, again, people in this audience should look up those kind of resources and find people who can give them the best care and really care about them.
I also think it's important to acknowledge a new entrant into the market, which is private companies that are providing, service-based care. It's no longer patients choosing between this health system or that health system. The consumerization of healthcare is real, and patients are now seeking out digital health providers that align more so with their social identity and feel, and where they feel welcomed and affirmed.
It's one of the I think biggest benefits in that came really of COVID has been people being able to access care maybe outside of their 15-mile radius of their homes, which allows for them to maybe find a provider who represents them in terms of what they look like, how they identify. Back to Melissa's point earlier, the importance, I believe it was Melissa's point, maybe Patrina's point, of being able to have that affirmation in engaging with someone who has maybe some of the similar experiences, or walking into an organization that has people that are part of the communities that our clients are part of. Jake, can you speak a little bit more of how the private sector is playing a role right now in really kind of advocating for, or maybe moving into the space of advocating for the need for health equity within the LGBTQ population?
Sure. I think the traditional healthcare model has kind of made it easy for us and left a very large gap. I like to say that hearts and minds are changed with good data, and so here's the data. It's trying to decide where to go with this, but I'll focus on the providers. So last year alone, the number of people who graduated from cardiology fellowship, these are folks who went to medical school, did a medicine residency, and then went on to a 2-year fellowship in cardiology and graduated as newly minted cardiologists. There's about 1,070 new cardiologists that graduated last year. According to the CDC, about 5.5% of the US population has heart disease. That's 18 and over. Right, so you're looking at over 1,000 newly minted cardiologists for a patient population that's about 5%. The LGBTQ population is about 7.2% of the US population right now. If you dig in a little bit deeper on that data, you find out that Gen Z, it's certainly higher. About 20% of Gen Z identify as LGBT. And so, in the next 5, 10, 15 years, we're talking about a significant portion of the population. The number of people who graduated from LGBTQ health fellowship last year, right, to treat a population, let's say, similarly sized, was 3. And this is the 3rd year that those fellowships exist. And that's the gap that we're talking about. And I wish I could say, as a product of the current medical education system, I wish I could say that it was nimble enough and quick enough to be able to respond to that gap in care. And I think there are great health systems that are helping to close that gap, and there are nonprofits that are helping to close that gap. Unfortunately, they're not able to move quick enough. And so that is where the private sector has opportunity. Which is to say that there is a massive gap in the population dynamics of the LGBT community and the providers that are actually able to address it. And so that's where I'm seeing, especially at the early stages, early growth stages, a lot of activity is folks trying to address that gap in care.
Just to tack on to what Jake said, the number of hours dedicated to training nurses, PAs, NPs, and physicians that specifies LGBTQ plus content is really de minimis, given the number of hours in training that people have to undertake. So I think a couple of years ago, the average was 10 hours overall. And that is probably increasing. I don't know what the current numbers are, but it is a small amount of training time allocated to LGBTQ specific health matters. I know in gender and women's health specific training programs for nurse practitioners and midwifery, it's really minimal. And those are really important encounters that people have to take care of their health, from cancer screenings to contraception, to general health and primary care related issues. So.
Melissa, in speaking to this idea of like very little training time kind of given to these kind of specific trainings for LGBTQ health issues as our LCSW on the call, what do you see as some of the common mental health challenges faced by members of the LGBTQ community and population?
Yeah, so I think the first thing that comes up for me is our youth are at a very increased risk of suicide due to lack of support, not only in their homes and society, but also when accessing life-saving healthcare. This can look like bullying in schools, abuse and rejection at home. They also face higher levels of depression, anxiety, and substance abuse. Individuals with marginalized identities as well, such as trans and non-binary people of color, especially Black trans individuals, experience depression at much higher rates than white trans individuals and cisgender people. And then I also see just a lot of anxiety around our political environment, right? So people are constantly assessing whether they're safe. Is my family going to be safe? Will my marriage be overturned? Am I going to lose rights to my kid? Will I still have access to life-saving, gender-affirming medical care? Am I going to walk out of my house today and be killed for being queer? I mean, these are things that not only my clients, but just the LGBTQ community are dealing with every single day the moment they turn on the television or they're scrolling through social media, listening to the radio music. And this is affecting their sleep, mood, and just their overall quality of life.
I think that's an important kind of point that you bring up too, of just the political environment. We have seen over the past year just the number of laws being passed throughout the country, barring children and now adults from gender affirming care. Even members, there's a lot of letters under the LGBTQIA plus umbrella, with even the plus in there, indicating that it is not just those letters, but there are even members like cisgendered gay men or cisgendered bisexual individuals, lesbians who have even been engaged in discriminatory behaviors or language to gender non-binary people, to trans individuals. I'm wondering, how do you work with someone and in terms of helping them to decrease that level of anxiety when that anxiety is real?
Yeah, I think naming that and not skirting around it, right? And just like validating that experience for them. And I think also just as a queer Latinx person, telling them that I feel the same way. There's something special and important about sitting across from someone who where you don't have to explain those things to each other because it's just understood. And so I think being able to validate that for them, working through coping skills, of course, but this is our reality and it's affecting both of us in the same room. And that sometimes is enough to be able to feel like, okay, I have this safe space right now where my provider understands me on many different levels.
I'm wondering, Robbins, Jake, Patrina, as other healthcare providers, what are some strategies you guys rely on and use to help it not only address the disparities that the LGBTQ plus community is facing, but also helping to reduce that stigma of accessing care, of talking, I think in particular about mental health care as non-mental health, kind of primary mental health providers too?
Back in the 80s, during the AIDS epidemic, there was a mantra of silence equals death. And I don't want to overblow that, but nowadays we do have, as Melissa was pointing out, a real crisis. I think that was even exposed even more during COVID, and it's a mental health crisis that we have in our nation, and our LGBT community is suffering from that. And I think the thing we have to do is silence is the problem. We need to be out talking about this. We need to show people what their options are and destigmatize it. You know, when I grew up, I was in a very religious household that was very opposed to LGBT type behaviors and identities, I should say. And it was tough. And, you know, I went through some dark periods and even at some point even had a suicide attempt. And I talk about that. I want people to know that's real, that happens, and you can get by it. You can overcome this. You can get to a great place in your life where you do feel stable and valued and appreciated. I share my story with my patients, with anybody. I want them to know that it's real and it's something we can overcome, and we have all sorts of tools to help. So we need to destigmatize, share our stories, get rid of the silence, promote healthy living, recognize there's a current problem, and then we can make real gains.
And this is probably an outlier kind of statement. Melissa, I'm wondering if you do any like somatic work with your clients, but we live in these particular bodies with particular skin colors and particular features, right? And we can't change those certain things about our bodies. We can change other things, but there are homes for our psyches, our spirits, the vital functions of the body. And I find like the hands-on interventions, if people are receptive to touch and being like present with another person, or movement of their bodies, knowing how we inhabit these spaces can be vitally important, because our minds can really run away, particularly if we have multiple marginalized identities, where we are unsafe for a multitude of reasons in this particular society at this moment in time. And so some practices, which are not curative, certainly, but they can go a long way in helping us, as Melissa mentioned, cope. And just that accompaniment that Melissa spoke to, and being present with people in a moment of need or just a moment of like encounter can be beneficial. That's not scalable, like in terms of like Jake's work necessarily, but the hands-on piece can be really valuable.
Perhaps I'll take that opportunity to segue into the big bad capitalist view on how we can approach this. I think getting back to what Melissa was saying about, some of the high-risk communities being children, adolescents, young adults, I look at that community and, part of my job is to see the opportunity that exists in providing care for those folks. And what the data shows is that the first touch point for a lot of these LGBTQ folks is when they're adolescents, and they're engaging with the healthcare system for mental health care or for sexual health, right? And those are things that really focus around a social identity specifically for the LGBTQ community. And so, when we talk about that patient's journey, recognizing that, there are probably, payers here and employers here and health systems here, when we look at that patient journey from that first touch point and moving forward, a provider or a health system, or a private practice, whatever it is, can own that patient journey as long as they are able to effectively and competently provide care in that moment. And to break that down to maybe an example of a single patient, if somebody is coming in for an issue concerning sexual health, and a provider is able to address that concern in a competent and culturally sensitive way, then who is that patient going to come back to when they need an allergist, when they need a cardiologist, right? There's a level of trust that is earned in that first encounter, and it's incredibly important, and it's better care. So not only does it represent a unique business opportunity, but it is providing better care. So it is a win-win on all fronts, and then gives folks leverage and access for preventive care, which is even taking a step further in improving both clinical and financial outcomes. So the opportunity is absolutely there to do good and do well from every stakeholder, that's working with these patients. And I think it's just, kind of worth addressing the capitalist view here, because it is absolutely aligned with the clinical view, if you really dig in on it.
Thank you. So I want to ask, and for myself, for my colleagues who've joined us today, what are some of the things that you think Forge Health can be doing to better and more effectively promote LGBTQ health, wellness, and equity, and hopefully what can we be doing as a model for the larger healthcare system within the community?
I'll chime in first. I think engaging with a lot of the innovators in the space, they're out there. One of the issues that I have found with academic medicine, traditional healthcare systems, is that they always think they can do a better job if they have the same idea as somebody else. But there are people out there working on this stuff. Violet's a great example. Plume is a great example. There are a million of them. Sometimes it's hard to find them. Sometimes it's hard to decide which one is right. But there are a lot of innovators in the space, and engaging with those makes the rollout of these health equity initiatives so much easier. And so even if it's pilots, if it's introductory calls, whatever it is, engage with these folks, get an understanding of what's going on in the space, and adjust your approach towards these demographics.
I think another thing that can be done is really just improving access. And so that means trying to accommodate as many insurance plans as possible, sliding scales, creating pathways that people who don't think they can access healthcare, mental health care because of cost, can actually do so. And I think, those are, like Jake is talking about, some innovative models that can serve everybody, not just the wealthy people who can afford it. I think that's really what we need to capture if we want true equity.
Katrina or Melissa?
I'll just echo the accessibility piece is it's critical, particularly for behavioral health stuff, and the cycles of care that people tend to have to engage in for long-term benefits. To echo what we've already said earlier, having people who represent the patient population in the chairs doing the behavioral health interventions and the work with the very time-intensive, labor-intensive work to have positive outcomes. But that accessibility piece, my youngest brother was addicted to heroin for many years, and he had to go to prison multiple times, and we have a very large family of 8 children, and it took multiple cycles of care for him to eventually become sober. I know that's the case for lots and lots of families, and for many families, it ends tragically, right? So that the accessibility piece is just critical.
And it's relatively easy to leverage the technology to improve access to care, right? Geographical boundaries are a thing of the past. And so kind of leverage the consumerization of healthcare, leverage the technology that has been built over the past couple of years, obviously catalyzed by COVID, and use it to improve access. Those resources are available.
I also like what Patrina said about having people that people can relate to. I'm out, and it's so fun in my office when I see patients, and I'm out to everybody. I advertise an out person, but I still come out to them in the visit to reassure them that I am like you, and you can just see their sense of relief, and their fears go away, and their anxiety, and they just open up and they say so much more. And that's really useful. And to your points, and Jake, yours as well, we want to staff and provide providers to people that are like them. So, some people in our community actually may not want to see me. They would prefer to see someone who's Black and looks like them, or Latinx and looks like them. So although I'm so proud to help someone who wants an out provider that they can talk to, they might want an out provider who looks different than me. And that's great. And, these kind of businesses and these models should incorporate all these different providers that can really meet the needs of the communities down to a really more finer parameters.
It's all amazing and great points. Thank you. I know we have some public questions that have come through. I think we're going to be having. There we go.
Yeah, hello everybody. What an awesome panel discussion thus far. Very engaging and so much useful information. One of the questions that we have from our audience includes, it's a little bit controversial, so we'll see who can tackle it. We are on a call talking about how we should be more inclusive. The given fact is that there are going to be some clinicians, some providers that just are not comfortable treating the LGBTQ community and just marginalized groups. Regardless of the reason why they are uncomfortable, how does a company deal with that and their clinicians when they are just really uncomfortable and not equipped to treat the LGBTQ community?
Melissa, I'm going to send that over to you first.
I have a lot of things to say. I mean, I think I'll be controversial back and say that if you're not comfortable treating the LGBTQ community and other marginalized individuals and people of color, then you shouldn't be in the system. So I don't think any amount of training or conversations or anything will change someone's values around that. So that's my answer.
I fully agree with that. And I don't want them as my colleagues. I don't want our patients to have to see these people, and they shouldn't go into medicine, and we should really screen that out. But what I'd also say, which maybe is controversial too, is, LGBT healthcare is a little bit of a niche, and there is a lot to know about it. And understanding pronouns and understanding the language and PrEP, for example, there's now 3 different products for it, including an injectable version of PrEP. For all of if you may not know, that's pre-exposure prophylaxis to prevent HIV. And, I as a doctor don't know everything about every field of medicine. As a primary care doctor, I have my knowledge to a certain extent in certain areas. And I happen to be an expert in this, but I can't expect every single one of my colleagues to know everything about PrEP. I wish they would, but they can't have that same expectation of me about everything in medicine because it's so expansive. So I guess what I'd also say is, although we don't want bad seeds who are providers, but there are many providers who are well-intentioned that just may not know enough, and those might not even be right for you. You may want to find someone who really specializes in what you need, and that's okay. And they're still good providers and good people. They just don't have the knowledge, and hopefully they get more, but they may not.
I'm going to take a slightly different tack. I often open a lecture that I give on intersections of assisted reproduction and LGBTQ folks with the statement that I know that the nurses and nurse practitioners and other providers in the audience do not necessarily feel open to working with patients and who don't necessarily understand how anybody could be other than cis het. And I invite them to listen with curiosity and an open heart, again, foregrounding that everybody deserves to be treated with dignity. And I don't disagree with Melissa and Robbins necessarily, but I know that it's probably impossible to ask others to like closet their values if I don't want to closet my own values. But having a posture of encounter and hope that there's some respect on the other side, because I think we're all foregrounding optimizing health and treating people with dignity.
Awesome. Thank you so much for those answers.
We just, I think Jake was about to give his insights, and I want to make sure.
Oh, yes, please, Jake.
Sure. Thanks, Michael. I would say, try not to make it about a moral discussion, right? It shouldn't be your values are different than my values, because I think at the end of the day, it's difficult to lead an organization making decisions from a place of differing values. But instead, and I'll use an example here with, let's say, primary care providers, where you go to a website, you're looking at a number of different primary care providers. They can easily put into their profile that they are willing to accept or specialize in LGBTQ health. But it's also possible to have kind of the opt-out method, right? Where you can say this provider does not want to see or doesn't see LGBTQ health patients, right? And let's see how it goes for them, right? We're talking about we're talking about a large portion of the population. And I would venture to say that they are going to see a decrease in the number of patients seeking care from that specific provider, and make it about that, make it about efficiency, make it about effectiveness, as opposed to a difference in value. The other piece of it is a traditional referral system. You go to an emergency room that does not have a trauma team, and a patient needs trauma care, they refer to somebody else. And so when providers are practicing out of their typical, and Robbins, this is kind of getting at what you were talking about, when they're practicing outside of their standard scope of practice and they don't understand the options around PrEP, have a system in place that allows them to refer to providers easily and effectively that do understand the needs of the patient, and make sure that that patient is getting the appropriate care.
I want to reinforce one idea here, though. In emergent situations, for example, somebody wants to have a birth in a birth center, and they are emergently taken to the ER, to the L&D across the street at a local hospital. And that the nurses in attendance and the physicians in attendance don't want to work with a trans person who's giving birth. I would really encourage those people who are providing care for that other person who's bringing yet another person into the world to find a way to be really respectful and caring. We know that morbidity and mortality in labor and delivery settings is really high, especially for Black women or Black people who are birthing people. And so I think it's critical for folks to dig deep, to try to encounter others, especially in emergent situations, with respect and treat them with dignity.
Thank you. To clear, at the very start of that question, it was prefaced it's controversial for sure. But I really love it. It's a nuanced question with nuanced answers.
Yeah, I love it. And one thing that I consistently hearing from all of you and the public has also heard is making sure that providers are educated about the community. One of the questions that did come through is a great kind of follow-up to that. Can you talk more about the efforts underway to expand continuing education and other forms of development to grow the competency of current providers? And if there's any particular organizations that are really pushing this forward that providers can go and get more education around, you can note that as well.
I'm gonna, Jake, I mean, I know you're interacting with a lot of different organizations out there. I want to start with you.
Sure. I guess I'm turning this into a Violet promotional talk. I think there are resources out there for CME for individual providers. They exist through organizations like the AMA or similar national organizations for different healthcare workers. But changing the system in which those providers are practicing is different, right? Getting personal education and changing the system that these patients are walking into are two fundamentally different things. And I believe that the latter has the potential for more significant impact. And so I would say companies like Violet that come in and help change the way a healthcare system approaches these issues and how a healthcare system educates its providers and its staff is really the way forward. Because it's you could teach someone you could give someone a fish, you could teach them how to fish. There's some saying around this where you have to change the infrastructure here. Having individuals educated in kind of one-off scenarios will be helpful for a number of patients, but it doesn't change the system. And so we have to change the system.
Katrina, you do a lot of education for I think newer people coming into the field. Do you want to speak to kind of access to that, or what you've seen, how you've maybe had a role to play in that?
Be ginger about this answer. I think larger institutions of learning, I think, like Jake is pointing out, systems level change is slow, but it will have a larger bang for your buck. I think, places like Penn have had a lot of internal movement on that front, where individuals are pushing for change in curriculum, in the med school and in the School of Nursing. I know in the Graduate School of Education as well, and probably the School for Social Work and Practice Policy, SP2. They're seeing change internally because, like, it's a consumer model. The consumers, who are the students paying for the education, want more of this content, right? And I think my friend David, who's currently a pre-doc, he'll be doing his postdoc soon, but he's focusing on LGBTQ curriculum for his dissertation work. I think it's slow but steady in an upward being a positive in a positive direction. But it is slow, even at large institutions with lots and lots and lots of resources. But I think Melissa spoke to this also, the younger generations are pushing for more and more and more of this content, which I think is really positive.
A simple Google search will come up with tons of really high quality LGBT affirming continuing medical education and courses and classes. It's out there. So really the problem isn't a lack of material. It's really a lack of interest in organizations and putting into practice and making a part of mandatory curricula. So it's just going to take some time and pressure to make that happen. And
representation on boards, that's important. that helps shift the systems. People who are on boards are at some level influencing where money goes. And that's important. And how things, and where money moves, structures change. So more LGBTQ people on boards, more BIPOC people on boards.
We know representation matters in a lot of ways. Melissa, did you have any other thoughts you wanted to, especially, I think, we have a lot of therapists, I'm sure on the call today, as our LCSW on the panel. Any thoughts on where people can be searching for this material, looking for it, exposing themselves to it?
I agree with Robbins. We have so much information at our fingertips. And also there are local people who are like boots on the ground, who are like doing this work, who are going out there and hosting workshops, and who are people of color, LGBTQIA identified. Search them out and find them, invite them into your companies and have them do this work, because they're really they're talking from lived experience, and they're really out there, kind of grinding and getting that information to where it needs to go. So I think locally, small businesses and just individuals who have practices, other therapists who have practices, who do workshops as well, I think is a really good resource.
Thank you.
All right. We have another great question, and I love the way that these are coming in, because they're like perfectly in order of how we can keep the party rolling here. So we talked about, what do you do when there's a clinician kind of uncomfortable, or a healthcare system that's not able to or not willing to treat the LGBTQ community? How about if there is a client or a patient that's coming in and they are anti-LGBTQ, and the provider has identified as being a part of that community? How does the provider handle that patient interaction?
I actually also want to expand that. How do you guys as providers handle having affirming practices, and you might have a client who walks in and feels uncomfortable with the affirming kind of nature of the practice too? And I'm gonna, Robbins, I'm gonna ask you to start us off with this.
So in our office and many offices, one form we ask people to fill out when they come in is a SOGI form: sexual orientation, gender identity. We ask where their gender was at birth and what their gender is now. And that form alone is a cue to our patients that something different's happening here. And for many people, it's a trigger. If they do not understand gender identity and they're misinformed or have different opinions, we have had people get very angry and say, "What's this? Why am I asked to fill this form out?" And it's a great learning experience. I actually am happy when these people come into our office, because it's really an experience for them to be confronted with an out provider who cares about and understands this community, and they can see that we're wonderful people giving wonderful care, and that we care about all communities. And I luckily haven't been in an experience where we've come to blows or even had negative words. I can just say, well, it's just it's a part of our human experience, and I explain why we do it, and they understand or they don't, but they understand who we are. And if they don't want to come anymore because it's really offensive to them, they could go elsewhere. But I rarely see that. They usually stick around, and I would hope over time it changes minds and changes hearts.
Well put.
Melissa, I'm curious. I know you work with quite a bit of youth as well. And working with youth, you might have differing opinions of what the youth is seeking services for, maybe them kind of wanting to work with you, and maybe their parent having a different experience with you. How does that all play out in terms of creating this safe environment, while maybe there being some tension and conflict about, you know, your identity as well as what that parent or that child is looking for?
Yeah, I think so. It's really tough. I think first and foremost, my client is the young person. I work majorly with adolescents, and so they do have privacy, and like there's just things that I don't share with parents. But I have most of the young people that seek me out are seeking me out because of who I am and who I serve. And I don't really get a ton of parents who are not on board with that. However, I've had the experience where some parents are getting the wrong idea of what therapy would mean for their queer child, and kind of looking as a way to like fix it. And so it's something that I really have, it's a delicate balance, because I want the young person to be able to have access to mental health services, and to be able to work through some of the things that they're struggling with. And I don't want their parent to cut them off from that. And so it's like really building the relationship with the parent and using it as an opportunity for education. Again, similar as what Robbins is saying, like if they don't, I'm an out person, so my practice is an affirming practice. Everybody knows this. That's how I market myself. So if they don't want to come see me, they don't have to. But if they are here, it's an opportunity for me to really work with the parent and educate them. And more often than not, I'm able to do that. But I kind of make it clear, like my job is not to make your child straight, or, you know, make them change their mind about, you know, being trans. Like that's not the work that I do. So it's a delicate balance between both relationships.
And I think, Michael, do we have time for one more last
I was
question?
going to say, I think we have about time for one more.
All right, so last question to the panel. We know that right now it is Pride Month and there's a lot of attention being focused on the issues that we're talking about today, but it shouldn't just stop here. So given that we have a couple of minutes left, what's the one thing that you would want people to kind of leave with, given that we shouldn't just stop talking about it at the end of the month? What are some of the things that you would encourage people to continue to do, continue to push forward? How can they be an ally ongoingly and not just during the month of June?
I think not being a bystander is really important. There's one thing between saying you're an ally and then actually making the effort and speaking out. And it could be, you know, whether you're at a family member's house or at a dinner party and you're hearing language and conversations that don't align with your values of who you are as an ally, and saying something, because that really makes a difference. And I know it's hard for people to feel like they can't ruffle feathers in certain environments, but we have to, because our people are dying at alarming rates, and their mental health is suffering, physical health is suffering. And so I think it's really important to just not be complacent, and to be able to speak up when you hear something.
I'm going to take that question into a little bit of a different direction, which is to say, lean into pride, acknowledge pride, make pride that 1 month a year where you go through your CME focused on LGBTQ health. Take the month and learn about the community. Take the month and better your clinical practice and your knowledge base around the needs that affect this community. And recognize that Pride Month is the month that you are going to improve yourself when it comes to providing LGBTQ healthcare. And that will turn you into a better advocate for the community, and it will turn you into a better provider for the rest of the year. And I can't imagine that there are a whole lot of people out there that do CME every month for the same exact condition, unless you're a specialist in that, right? So consider June your opportunity to really further your own clinical and medical education in this space.
I thank you for those thoughts. And, you know, my parting advice is for everybody to recognize that you are valued, you're good, you're worthy of love, you're worthy of acceptance. And for that, you should recognize that. And once you can internalize that message and realize what a beautiful person you are being part of the LGBT community, then once you feel comfortable with yourself, you can enact change in the world. So understand yourself, know that you're worthy, and then share that message and make change in the world by being an out positive influence.
Katrina, do you want to bring us home?
I mean, here to what everybody else has said. I think Robin's message goes for everybody. The more accepting you are of yourself, the less volatile you'll be with other people potentially. So if you're an ally, I think grist for the mill is self-acceptance too, and showing up for people who are not exactly the same as you.
Wonderful. Before we kind of wrap up, I want to make sure that I extend thanks to the members of Forge's HR, IT, marketing, and business development departments and teams for helping to organize the event and ensure that we were able to put this together. Without them, we would not have been able to have this wonderful conversation today. So I wanted to ensure that we thank them. And Robbins, Melissa, Patrina, Jake, thank you guys so much for joining us today, speaking about this really important topic. Healthcare equity is something that it's easy to, in any month, easy to say it's really important. It's harder to put it into practice, but I think you guys gave us some really concrete, great ways of really thinking about how we can change our practices, being able to be more affirming, being able to really ensure that we are validating and seeing each person as an individual when they come in. Again, easy words to say, harder to do every single day, but truly just remembering that each person who comes in, that we engage with them as that individual, seeing them as a full person. So I appreciate your time and energy spent with us. So thank you so much. And for everyone who was able to join today, thank you guys for joining. It is really important. And as we said, it is Pride Month. I love that it is Pride Month, but we also do treat LGBTQ clients the other 11 months out of the year. So ensuring that we continue to